Okay. Hi. Hi.
Good morning.
Let me just tell you that 40 out of 42,
Good morning.
40 out of 42 people passed their math.
Yeah, you did.
Let's get it.
What you say? I didn't hear you.
40 out of 42 people passed their math. That's
Amazing
unbelievable.
what can happen when we get
Woo!
taught stuff.
First of all, you guys, you did the work. I can't take credit for your work, but I can take credit for taking the time to do the work with you.
Thank you for helping us, Mrs. Simmons. Thank you.
Of course. Thank you for being so good.
Thank you for all of your help, really.
Yeah, you've been awesome.
Miss Simmons, are you done great in this test? Because my feelings are a little hurt. I'm not going to lie. Everybody in my class got points back except for me. I didn't get not
That's
0.01 back.
Actually,
Wait,
that's because, girlfriend, you got all of your select alls correct. You were the only one, I think, that got all of these select alls that correct. You also got the correct answers that everybody else missed. So you did not get any points back because
I know,
you already
but
got them right.
people had worse grade than me, and now they all have better grades than me. And my feelings are a little hurt about this. And you're laughing, but I really just had a crash out, and I was crying. And I'm not. I don't like this.
No, I'm very, very proud. I'm very, very proud. Also, for the first time in my
not
life
proud.
ever, somebody got 100%, which is ridiculous. And they got 100% because of the points that I gave back. So they had a 95, or they had a 90 something. They got 5 points back, which
I wish I could get 5 points back.
5%. It was 5%. I don't know, but they ended up getting 100%. And I was like, what? I almost was like, ooh, maybe I shouldn't have given that many points back. But listen, first of all, Brandy, if you didn't get points back, that means that you got the correct answers. You should be proud of that.
I'm not feeling very proud. I'm feeling like now.
Oh,
It's not funny. My feelings are really hurt.
I understand. I really do understand. But I do also need you to understand that you had the right answers, and I'm really proud of that.
So how do we do on the bow tie?
The bow ties, the average score was 4.1 points out of 5, which is just.
Can I ask a question? Can I ask a question about a specific question?
No, you cannot. No, you
No.
cannot, because
Okay.
there's one person on here that did not take their exam.
Okay.
And which sucks because I have never experienced that before. And I don't know. I cannot go over any exams.
I'll just
email you then
I'm just
with a
curious
question?
as to if
Hold
I'm-
on. I cannot go over any exams at all until that person takes their exam.
Okay. I had a question, so just about one for my own knowledge. So I'll just email it to you.
Email, yeah, you can email it to me. But
Okay.
when they do, I'll be able to go over exam material. Why is Tiara on hold? Did I do that to her? I don't know. But I am so very proud of you guys for your math. So proud. Oh, that's what, okay. So, the only thing that I'm going to tell you, and I want to help you in the future when you are thinking about select all that applies. And this is really specific to, I don't know if this is in a general stance, but it's very specific to me. Okay. So I want you to think about something. I have a 50-point test over what, 9 chapters, 8 chapters, and there's 38 questions. So if my select alls are worth multiple points, I can't just spend all my points on select alls, right? My bow ties are worth 5 points. That's standard, right? All bow ties are worth 5 points. There's nothing I can do about that. But with select alls, I am never going to waste 5 points on a select all. It's never going to be 1 point because then that's not a select all. Your best bet is always going to be between 2 and 4. With like 80%, 70% being 3. %, being 2, and maybe 5%, which is rare, ever being 4 answers. So let that help you in your future endeavors. Okay? And I can tell that even though the person that didn't take their exam, I can say that because those were already like given back, 2 of the select alls. So when they go and take their test, they automatically are going to be adjusted. So I don't have to go in and manually adjust their exam. So there's no reason that I can't say that in front of everyone. So, but anything particular, more particular to the test, I can't talk about it. I uploaded the video to Brightspace. Did you guys see it? I figured out how to embed videos. So as soon as you go in there and you click on it, it should just be like ready to play. Please let me know if you have any issues with that. So we left off on chapter 52, I think. Yes. I feel like the map really just changed. What happened? It was like, and now it's like, ooh. What happened? Too much excitement, and now it's all gone.
I think it was irritation. That's why. Yes, girl. Yes.
Irritation?
Because
Why are you
listen,
irritated?
I knew this stuff. I knew this stuff before I walked my ass into that exam today.
Please
I
be
know.
careful with what you say because,
I knew it.
okay. Not because of
Oh,
me,
no, I ain't gonna
because I
give
don't
that
want
away,
you
girl.
giving anything away.
They ain't about to get that from me, not me.
Okay. Okay,
And I was
so
so confident that I have read stuff.
you know what happens when you're too confident? It bites you in the butt.
You don't do well.
It bites you right in the tushy.
It sure does, because you know what? There's a question I answered, and as soon as I clicked next, I said, "You big dumb," so on and so on.
Who else? You just said one of my girls here said the same thing. As soon as she was done, she's like, I literally picked the wrong answer. I hit next, and then I'm like, why did I do that? What?
Right.
I do that to myself.
Because I was too excited and too happy because
I
I knew
was
what
too
answer for sure.
excited. I gave you too much joy, is what you're saying.
Girl, oh my God.
You'd be like, if you spend too much time on something on your phone anyway, you spend over them on stuff.
Miss
You know,
Simmons.
it used to be back when we used to take tests, like paper tests and Scantrons and stuff. It always used to be like pick C because that's like process of elimination. You're going to get it. But now with computerized testing, everything is randomized. Your questions are randomized. Your answers are randomized. So now you can never just pick C because it's never the same as the way that I put it in. So don't ever do that. Don't ever do that.
Miss Simmons,
Yeah.
did you ever do your Calendarly link thing?
Yeah.
Okay.
Yeah.
Thank you.
Let me send it out in the group email. But also, I want you to remember, I cannot meet with all 43 of you individually. So when the other exam gets taken, I am going to do a like overall exam review. We're starting with chapter 52. And then the people that got SAPs are going to meet with me individually, which I've already sent them correspondence. So if you would like to meet with me individually after all of that, like after we go over the exam all together, just shoot me an email, let me know, and I'll see if I can like work you in. Because I never want to say no. You know what I mean? Like I never ever want to be like, no, I can't meet with you or I can't talk to you. Because you know, that's not cool. So if all 43 of you are looking for a Calendly link to, you know, I'm gonna run out of time slots very easily. Okay. Okay. Did everybody eat? Did you eat? No? No lunch? Why? Yeah.
Mrs.
She's like,
Simmons.
I said I ate. What?
I'm sorry, but my are still not scrubbed. Like
Who?
I had one from last week. Leah Brown.
Oh, yeah. Hi. Do you have a different email that is not your Ross email on your Lippincott?
I don't think so. I'll double check, but I'm pretty sure it's my Ross email.
Okay. Double check, send me an email.
Okay.
And I will forward that to Justin. If anybody else is still having issues, please let me know. It should have been done for everyone by now. So let me know if it wasn't, okay? And guys, make sure you're turning on your cameras. I really don't want to have to go back through video footage to see if you're actively here or not. Okay. A lot of you are so good at like being vocal during class that I don't really feel the need to look. But don't take advantage of that. Okay.
Miss Simmons, I just sent you a message about my camera. My iPad is on like 2%, so my camera won't turn on to it like
Okay.
at 10 or 15.
Okay. Well,
Okay.
you better plug that in, girl.
It's on the charger. It's on 8%. It's just, it says your battery is low and your video is paused. So I'm just waiting for it to get some juice.
Oh, okay, so we are finishing up renal with this chapter. So this chapter is all about drugs affecting the urinary tract and the bladder. So urinary tract infections, UTIs, this is the second most common infection in the US population. People with shorter female urethras are particularly vulnerable, which we talked about yesterday, because the urethra is so much shorter than the male urethra. It is extremely more common for females to get UTIs. It's actually extremely rare for a male to get a UTI unless they have some type of primary situation like BPH, which is benign prostatic hyperplasia, some type of urinary retention, urinary incontinence. Now, this is not very PG-13, but some people like to put things in their urethra when they're not supposed to go in their urethra as a pleasurable thing for some humans. Not saying it's wrong. I'm not icking anybody's, fun things. But when you introduce things into the urethra, that's how bacteria goes in, especially for a male. And then another really common reason is self-catheterization or a lot of catheterizations within a facility. Children may also have frequent UTIs, especially little girls with like bubble bath solution. I was one of them when I was little. I think, God, I was like 3, 4. I remember my mom like making me chug cranberry juice. Still hate cranberry juice to this day, by the way. But yeah, little girls are very susceptible to UTIs. Patients with indwelling catheters, of course, intermittent catheterizations often develop bladder infections or cystitis. Not so fun fact, if you ever do go into pediatric nursing, and you see young children that have a lot of UTIs that aren't really explainable, it could be because of sexual assault and molestation. So if you do go into pediatrics, that is something that as a mandated reporter, you should always be not looking for, but, recognizing. So signs and symptoms of a UTI, most of us are women. Most of us probably have had at least one UTI in our lifetime. So we have urinary frequency, urgency, burning on urination, chills, fever, flank pain, and tenderness. This is when things start to take a turn. Okay. When your UTI symptoms just go from this, where it's frequent, urgent, and a little burny, and then they go into chills, fever, flank pain, that is what we call pyelonephritis. Okay. Some people may suffer from nocturia, which is nighttime urination. Older adults, sometimes their only presentation is confusion, disorientation, and other central nervous system situations. And that's with males and females, older men and women. So treatment for UTIs, of course, is going to be antibiotics. Other drugs are going to be drugs that block the spasm of the urinary tract muscles, decrease urinary tract pain, protect the cells of the bladder from irritation, and treat enlargement of the prostate gland in men. So anybody ever taken over-the-counter Azo? No?
Yes.
Yeah, girl. Yeah. Listen, the first time I ever took Azo and I did not read the box and then I went pee. By the way, it took away all my pain. But then I went pee and I looked in the toilet and it was orange. And I was like, what's happening? Am I dying? Azo.
I actually thought my infection was worse because I saw that.
I literally thought that my kidney and I was gonna die. This was before I was a nurse. I was I think I was like a teenager or something. And I was like, what is happening? I'm dying. Azo specifically turns your urine reddish orange. You should write that down.
One time my stepson took it in the middle of the night because he had a headache. And so the next day he said, I ended up taking him to the hospital not knowing that he took the Azo because he had the orange urine. And then when we got home, I said, well, show me what it was that you took. And then he said, I'm like, oh, that's for UTI.
Oh, no.
Yeah, that was fun.
Yep. I'm sure it wasn't funny in the moment, but yes. Yes, definitely. Okay. So we talked about the structures of the urinary system yesterday. So here we have our ureters, which come from each kidney, right and left. The bladder is a muscular empty space. and that goes to the urethra, which then exit the body. The prostate gland, which is only found in men, I hope we all know that, only found in biological men, surrounds the urethra. Okay. So when a man has issues with their prostate, like BPH, which is benign prostatic hyperplasia, or prostate cancer, something that is causing swelling, or growth of the prostate gland, you have to think about the urethra like a straw, and the prostate surrounds the straw. So if you're squeezing the straw, it's going to either make the stream that comes out very small, or it's going to stop it completely, which we call obstructive. Okay. And men with BPH usually have frequency because they can't empty their bladder all the way. They usually have urinary retention because they can't empty all the way. And then they usually complain a lot about nocturia. So anti-infectives that we use for UTIs, antibiotics specifically, you have fosfomycin, nitrofurantoin, and trimethoprim. So not gonna lie, you don't really see any of these, okay? Because the thing is that people overuse antibiotics, and now the bacteria are very, very smart, so are viruses, and they adapt and they become resistant to antibiotics. So now we have all of these drugs that are more common. Okay, you have your ciprofloxacin, oxofloxacin, levofloxacin, cefixamine, Bactrim is a really common one. There's something very specific about Cipro that I'm going to tell you. And I don't know if it's coming up on the slides, but we'll get there. And if it doesn't come up on the slides, I will tell you about it. So some of the antibiotics act specifically within the urinary tract to destroy the bacteria. Trimethoprim works systemically, which means all over the place. Okay. These other two are used to treat susceptible gram-positive and gram-negative pathogens. That means that they're broad spectrum. So if an antibiotic treats both gram-positive and gram-negative, that's what we call broad spectrum, meaning they cover all of, like both, gram-positive, gram-negative. So obviously your indication to take these drugs is the treatment of a UTI. Obviously, we don't want to take antibiotics if we're allergic to them. You want to be cautious with really all antibiotics. Not all. So some are more nephrotoxic than others, but most all of them can cause some type of injury to the kidney. That doesn't necessarily mean they will. That just means if your patient already has kidney issues, like chronic kidney disease, that you should be cautious with which antibiotic that you choose. So pretty much all antibiotics are going to have nausea, vomiting, diarrhea, okay? Because they just tear you up. Also, another thing that almost all antibiotics are going to put you at risk for is yeast, candidiasis, oral, vaginal, right? People get yeast infections all the time from taking antibiotics. Okay. Infrequently, blood dyscrasias, pruritus, urticaria, headache, dizziness, nervousness, confusion. These are things that you would want to notify someone of, right? If you were experiencing these are infrequent, but they're also weird. Like, hey, I should probably call someone if this is happening to me, because this is not a normal thing for antibiotics. Okay. Drug-to-drug interactions occur with each varying agent. So this one is looking closer at phosphomycin. This is the treatment of acute uncomplicated UTIs caused by susceptible strains of bacteria. And when we get into antibiotics, I believe is next week when we really dive heavy in there. There's different ways that antibiotics break down the bacteria. So this one interferes with cell wall formation of gram-negative bacteria. Okay. If your cell doesn't have a cell wall, it will be destroyed. Okay. So if it's interfering with the way that the cell is structured and how it's keeping all of its contents inside, it cannot survive. And next week, when we go over antibiotics, we will dive into all the fun ways that antibiotics work. So a 3-year-old is diagnosed with a UTI. Which drug can the nurse expect to be prescribed? This is a dumb question. So the answer is D, but it's specific because it's indicated for use in children 2 months of age or older. And none of the other antibiotics are should be given to children that small. Okay, so let's see. Why put a question in here about age if you're not even going to go into specific detail about age? So I am not going to either. Oh, okay. Under pharmacokinetics, it does look at it. So phosphomycin taken orally has the convenience of a one-time dose. It is not recommended for children younger than 12 years of age. It's rapidly absorbed. Nitrofurantoin is also administered orally. And that has no indication for age. Nitrofurantoin and Bactrim are to be avoided in the first trimester due to possible risk of congenital anomalies, but they can be given safely in the second and third trimester. Interesting. Okay, we're not going to hit really heavy on antibiotics for this week because we're hitting it so hard next week. So I don't want you spending a lot of time on antibiotics for UTIs. Okay? I want you to spend time on the rest of it. All right? So, urinary tract antispasmodics. These block the spasms of urinary tract muscles caused by various conditions. We have anticholinergics. Oxybutynin is definitely going to be your most common medication for an antispasmodic. I've also seen this one, this Mirabegron. Also seen that one. But oxybutynin definitely is very common. And it also comes in a transdermal patch, which is interesting. So you can put that transdermal patch literally like right, above your bladder. Not that you would have to put it there. You don't have to, but you can. It's a transdermal patch that can go anywhere. So the way that these work is that they block parasympathetic activity, thus suppressing overactivity. This leads to the relaxation of the detrusor and other urinary tract muscles. So the muscles that actually cause your urinary contraction. So also, we need to think about our negative feedback system, right? So our bladder works by stretch receptors, okay? So when the bladder becomes filled and then filled and then filled, and it becomes to a certain like line in the bladder, which by the way is different for everyone, your brain just gets a signal like, hey, your bladder's full, you gotta pee. And that is from the stretch receptors that are within the bladder wall that feel that stretch. Okay. Indications would be for bladder spasm, treatment of overactive bladder, and other indications varying by specific drug. Have any of you ever worked on med surge for men that are post-op from like a TURP, which is a prostate procedure, where you have something called a CBI, which is called continuous bladder irrigation? Okay. So there are some procedures, mostly for men. They can be for women if you're dealing with a lot of cystitis or something going on within the bladder that they have to go in and clean out. But this is mostly going to be men for continuous bladder irrigation. It's a 3-way catheter. It has a large diameter, which I'm sure is quite uncomfortable. And you have saline that goes into the bladder, and then you have another way of coming out of the bladder. So that fluid goes in, irrigates the bladder, and it's continuous. Water going in, water coming out, water going in, water coming out. It is constant, okay? And depending on how far post-op the patient is, how much they're bleeding, that urine, which isn't really urine, it's diluted saline mixed with just a little bit of urine, is usually either quite bloody, like a cherry red, or it can be all the way to like a light pink lemonade. Grapefruit, there's, for some reason, they use a lot of fruit terms to distinguish the color of the continuous bladder irrigation after it comes out, obviously. And it's extremely important to watch that and make sure that you're not staying at a cherry red, because that means that you're bleeding, that the patient is bleeding significantly. We need to decrease that bleeding, okay? Which is the whole point of a CBI. But the reason we're talking about this is because this causes really bad bladder spasms in these patients. I mean, because think about it, your bladder is being forced to expand, which is constantly telling your stretch receptors, hey, something's happening, we're full, why is this happening? So it's triggering your bladder to spasm, okay? So antispasmodics are rapidly absorbed. They have a slow onset. They're metabolized in the liver, excreted in the urine. They're contraindicated with pyloric or duodenal obstruction. Why?
Because it's stopping the spasms, which you would need for the obstruction. For those
So where is
muscles?
your pylorus? Where's your pylorus?
Is that in the intestines?
So that is right at the end of your stomach, where your stomach goes into your small intestine. Yes. So, let me find it. Let me find it. I apparently wasn't highlighter happy in this chapter. It's got to have something to do with the sphincter.
because at those junctions you have sphincters, which are muscles. So if you are slow or stopping the spasm of, oh, here it is. Surgery because complications. That's literally all it says. That's really dumb. But it would affect the sphincter of the stomach, which could cause backflow of contents that are within the small intestine in the stomach up into the esophagus. Am I cutting out for you guys at all? Because I just realized I'm not on my hotspot.
No, we can hear you.
Okay. Rachel, I am cutting out for you.
Yeah,
It did break up for a second when you were just explaining that.
Okay, let me just put it on just to be safe. Because I have also found that if I break up during class, it's also like that on the recording. Okay, can everybody hear me? Can you hear me?
Yeah.
Okay, good. Okay, so antispasmodics can affect sphincter muscles by relaxing them, which can cause a range of issues from harmless side effects like blurred vision and dry mouth to more serious problems like urinary retention, aggravation of gastroesophageal reflux disease, which is GERD. It is crucial to use antispasmodics with caution and only under medical supervision. They may be contraindicated for individuals with conditions like enlarged prostate, urinary tract blockage, or glaucoma, because guess what? Your iris in your eyeball is also a sphincter muscle because it contracts and dilates, right? I'm actually looked that up on Google because it's really important, and I don't understand why they don't go into more detail about it in the book. Because if this is also affecting your pylorus, it's affecting all of your sphincter muscles in your stomach, then what do you think your patient is at risk for? Especially if you lay them down flat. Aspiration, right? So to me, in my book, that's pretty important. Okay, so you want to use caution for patients with renal or hepatic dysfunction because it is metabolized by the liver and excreted in the urine. Pregnancy and lactation. With mirabegron, you want to be very cautious with patients that are hypertensive. Okay, that's a zebra for antispasmodics. Adverse effects are related to blocking of the parasympathetic system, which I just talked about. Okay, with the sphincter muscles that can be either harmless or go to very serious. Your drug-to-drug interactions would include phenothiazines and haloperidol. Haloperidol is very common in what population? psych, and
The elderly.
geriatric. Haldol is given out like Skittles in some psychiatric and elderly facilities. So this is taking a closer look at oxybutynin. This, the indication is relief of symptoms of bladder instability associated with uninhibited neurogenic and reflux neurogenic bladder. It treats the signs and symptoms of overactive bladder. Treatment of pediatric patients aged 6 years and older with symptoms of detrusor overactivity that's associated with a neurological condition like spina bifida. So if you have a patient who's 6 years old and older that has spina bifida and they have a very hard time with overactive bladder symptoms or controlling their bladder because of bladder spasms, they can take this medication. Okay. Adverse effects include drowsiness, dizziness, blurred vision, tachycardia, dry mouth, nausea, urinary hesitancy, because it's going to be hard to start a stream if you have no spasmodic muscles causing your bladder to empty. Okay. Decreased sweating and angioedema. Not many drugs cause angioedema. Any questions about antispasmodics? Did somebody find the page it was on? Did I just see that? Page 934. I'm on page 934.
I thought she was asking me where you were reading from.
Oh,
Or
I thought you
asking
meant
where you were,
I thought you meant that you
was when you were reading from Google or not.
a lot of this is on page 934 under adverse effects. I would love for you to go back to that area.
One more time for the page number.
934. Adverse effects. I also want you to take a look at the drug-to-drug interactions. I know that the slide didn't really go into it, but there are a lot of really severe drug-to-drug interactions in this classification of drugs. So with phenothiazines and haloperidol, in conjunction with oxybutynin causes decreased effectiveness. It just kind of gets worse from there. So if they take darafenacin or fesoterodine is combined with antifungals or antivirals, there's a risk of toxic effects. The dose of darafenacin or the other F1 must be reduced. There's a risk of increased QT interval and serious cardiac arrhythmias. If solifenacin is combined with other drugs that prolong QT interval. What was a drug that I literally just talked about with cardio that prolongs QT intervals?
Zofran.
Zofran.
Well, if your patient is taking Zofran and then is also taking oxybutynin, or I'm sorry, solifenacin. I hate these words. You're at a very large risk for prolonged QT interval. What happens when you have a prolonged QT interval? What kind of symptoms do you have? It's going to be a lot of CNS. And what I mean by that is syncope is going to be a huge one. Syncopal episodes with QT prolongation. but also you're going to have that dizziness, lightheadedness, fatigue. Okay. So I want you to look at that paragraph on page 934 for drug-to-drug interactions, because I promise you I'm going to get something from there. It feels important to me. All right, so we're moving on to urinary tract analgesics, which is where our azo comes in, and our orange urine. So pain involving the urinary tract, by the way, pain and burning when it comes to urinary symptoms can both be classified as dysuria. Okay, so when you see the word dysuria, I want you to associate that with pain and burning. Okay. So, pain involving the urinary tract can be very uncomfortable, very, very uncomfortable. Can lead to urinary retention and increased risk of infection. The phenazopyridine. Pyridine. I want you to remember pyridine. Most of drugs, if not all drugs, that have this suffix pyridine is going to cause that discoloration in your urine. Okay? And it is a dye that's used to relieve urinary tract pain, which is why it causes red or orange urine. The azo, the phenazopyridine, is a dye that's used to relieve urinary tract pain, which is why it causes discoloration. So this exerts direct topical analgesic effect on the urinary tract mucosa. So it works in a localized way. So this isn't like you're taking Tylenol, and Tylenol works systemically, right? It's working on all of your pain receptors. It doesn't know you have a headache. It doesn't know that your finger hurts. It's addressing all pain receptors so that wherever the pain is that is affecting those pain receptors is then relieved, okay? So when you're talking about something that is localized, it's actually affecting the urinary tract mucosa specifically. Okay. It relieves symptoms related to UTIs from infection, trauma, or surgery. It has a rapid onset of action, thank God, because dysuria can be very unpleasant. It is widely distributed, metabolized in the liver, excreted in the urine. It crosses placenta and enters human milk. That would be weird. I wonder if it turns breast milk red or orange. That would be interesting. It is contraindicated in severe renal or liver dysfunction because it is metabolized in the liver and excreted in the urine. And you want to be cautious in pregnancy and lactation. So adverse effects, GI upset, headache, rash, reddish orange coloring of the urine, staining of the contact lenses. That's important. What is that important for? To educate your patients that, hey, if you take this medication, it's going to stain your contact lenses. Make sure you have a backup, because then you're going to be walking around with orange eyeballs. Okay? Because it also stains your tears. Use of the drug for longer than 2 days is not recommended. Why? Okay. If you have to take azo for more than 2 days, you are walking into a much more complicated situation than what you started with. Okay? So, if, say, you started on you went to urgent care, you said, oh, I have a UTI, I just started taking azo, and they give you an antibiotic. Cool. You go home, you take the antibiotic. The next day, you take the antibiotic. You are like, wow, I'm still having a lot of pain. You take more azo. And then you take another antibiotic. I'm still having all this pain. I'm taking more azo. No good. How fast do antibiotics usually work?
Like 48 hours?
You're going to feel some relief of symptoms from your antibiotics within 24 to 48 hours, depending on the severity of the infection, by the way. But normally, with any old infection that's not, crazy sepsis, you should feel some type of relief within 24 to 48 hours. If you are still severely symptomatic, getting worse after 24 to 48 hours, you must call your provider. I want you to put a star next to that. You must call your provider and say, hey, I am not getting better. My symptoms are the same or progressively getting worse. I do not think that this is the right antibiotic for me. Because what happens to bacteria over time? They adapt, they adjust, they become resistant to antibiotics. So if you happen to have a bacterial strain that is resistant to the antibiotic that you're taking, it's not going to work. If you do not handle that bacteria appropriately, it is going to progress from a UTI, probably all the way up those ureters, all the way up into the kidneys, causing pyelonephritis, which is then you're going to have your chills, your flank pain, your fever, okay? So untreated is going to back up all of that bacteria all the way up the ureters, all the way up into the kidneys. And that's where we start having real issues, is when you have a severely infected kidney, okay? Apparently, it could interfere with the urinalysis because of the color reactions. That makes sense. Because a lot of urinalysis tests are like those dipsticks that change colors for pH and things like that. So if the azo is changing the color of your urine, it could change the color of the urinalysis dipsticks. Makes sense. So this is taking a closer look at azo. I want you to be able to recognize both names. Okay? Please be able to recognize both names. I'm just saying azo because that word is hard for me to say. So we've already discussed that it's indicated for symptomatic relief of pain, urgency, burning, frequency, and discomfort related to lower UTIs caused by infection, trauma, surgery, or various procedures. It works directly on the urethral mucosa. Adverse effects include headache, rash, yellowish tinge to the skin, which is not common. I would probably notify a provider if your skin or your sclera is turning yellow. Why?
Jaundice.
Jaundice.
Metabolized in the liver. So we already said it was contraindicated in severe renal and liver disease, right? So if you're turning jaundice while you're taking this medication, something's wrong and you need to notify a provider. Okay. So when you're talking about coloring in this situation, recognizing yellowing skin and sclera being bad and notifying a provider versus my contacts turned orange and my urine is red being a normal adverse effect that you want to educate your patient, right? You want to educate your patient in both ways. Hey, if this happens, this is expected. If this happens, you need to tell somebody. I would need you to know the difference, okay? What is an appropriate nursing conclusion for a patient taking a urinary tract antispasmodic?
A.
Okay.
The answer is A. Risk of impaired urinary elimination related to the parasympathetic blocking. So, nursing conclusions related to drug therapy might include impaired comfort related to GI, central nervous system, or ophthalmologic eyeball effects, altered sensory perception, which is visual, because remember, we were talking about blurred vision. Okay. Knowledge deficit regarding drug therapy, and then risk of impaired urinary elimination related to the parasympathetic blocking. Any questions about the antispasmodics? I do want you to know stuff about this classification of drugs. So, UTI antibiotics, not so important. Antispasmodics, more important. So bladder protectants, these are used to coat or adhere to the bladder mucosal wall, protects it from irritation related to solutes in the urine. This is especially important for patients that have like chronic cystitis, which is inflammation of the bladder wall. This drug is called Pantosin polysulfate sodium, Elmiron. There's only one of them. So the therapeutic action, it is heparin-like compound that has anticoagulant and fibrinolytic effects. It adheres to the bladder wall, mucosal membrane, and acts as a buffer to control the cell permeability, which decreases the irritation of the bladder wall. So it prevents irritating solutes in the urine from reaching the bladder wall cells. It's like, we're going to get into GI, but there's a drug called Carafate that when you take it, it coats the inside lining of the stomach to protect the stomach. This drug is coating the inside of the bladder wall to protect it from things that could hurt it, ulcerize it. So the indications is to decrease the pain and discomfort of interstitial cystitis. The pharmacokinetics, little of the drug is absorbed. It's distributed to the GI tract, liver, spleen, skin, bone marrow, and periosteum, metabolized in the liver and spleen, excreted in the urine and feces. And it's contraindicated in any condition that involves increased risk of bleeding and a history of heparin-induced thrombocytopenia. So if you have signs of bleeding, like bleeding gums, GI bleed, petechiae, hematuria, ground coffee emesis, coffee ground emesis, I feel like I'm missing one. But these are all classic signs of bleeding, right? Of thrombocytopenia, okay? So, contraindicated with a history of heparin-induced thrombocytopenia, because what did we say? It is heparin-like. So it has the same molecular components of heparin. It's metabolized in the liver and the spleen, so you want to be cautious with patients that have hepatic or splenic dysfunction. Adverse effects include bleeding that can progress to hemorrhage. So this would be a huge thing to assess for and look out for, right? Can cause headache, alopecia, and GI disturbances. Drug-to-drug interactions include anticoagulants, aspirin, or NSAIDs because of bleeding, your increased risk of bleeding. Okay. These are also a set of drugs that I want you to know things about. These are drugs for treating BPH. What is hyperplasia? Is it benign? Is it malignant? What does that mean? It's not cancer. Okay. So what is hyperplasia? Hyper, so something is happening a lot.
Does it have to do with thickening of the blood, or am I just guessing?
So hyperplasia is a way of talking about cell overgrowth. Okay. So when you have a malignancy, a cancer, cancer is the abnormal growth of cells. Something's wrong with those cells, and they are growing at a rapid rate, which causes a tumor, right? So, which is bad, obviously, because it invades the other tissues around it. Hyperplasia is the growth or overproduction of cells in a non-cancerous way. So this growth is what's causing the enlargement of the prostate without malignancy. Okay. So
Jess,
it is
I have
a
a quick question for
similar.
you.
Yeah. Go ahead.
Oh, sorry. So when you say
ahead.
growth, do you mean like repetition? Sorry. When you mean growth, do you mean like the size of it, or how many cells there are?
Let me show you. Let me show you. Let me show you. Okay. So this is a normal prostate, okay, where the urethra goes right through it, okay? This is BPH, where you have an enlarged prostate that it grows inward and is cutting off or narrowing the urethral opening, okay? So it usually grows inward. It can grow outward, okay? But it causes the tissues to become very enlarged. So there's a difference between Harry, just hang up on them. Okay. Yeah, but it's not fun. Ah. Straight. Just right here. Sources. as an actor. That's why, but this computer is beyond me. Okay, this is important for the rest of your education, which is why I tried so hard to get it back up. Okay, so these are your normal cells. Okay, hyperplasia is all of your normal cells, but they're just really big. The cells are bigger. Okay, dysplasia is when they're bigger, but they're not in the right place. They're displaced. The pattern isn't correct. Okay. And then you have malignancy, which is an overgrowth of tissue. So in every situation, it's an overgrowth, right? One is harmless, except for causing increased growth that can cut off the stream of urine, specifically in this situation. Dysplasia is, ooh, that doesn't look right. Something bad might happen here. Okay. And then we jump to cancer, which is obviously bad. Okay. So knowing the difference between hyperplasia and malignancy, or hyperplasia and dysplasia, is going to be important overall throughout your nursing career and when you take your NCLEX too. Okay. Okay. We are going to finish this slide and we're going to take not this like this chapter. Okay. So these drugs are for enlargement of the glands surrounding the urethra. So they are indicated for the discomfort, difficulty in initiating a stream of urine, feelings of bloated because the bladder is so enlarged, increased incidence of cystitis, which is inflammation of the bladder wall. There's two classes of drugs that assist in decreasing these symptoms. You have your alpha adrenergic blockers, and then you have your drugs that block the conversion of testosterone. There are important things that I want you to know about tamsulosin, which is Flomax, and finasteride, which is Proscar. So the therapeutic action is different with each drug. Obviously, the indication is the treatment for BPH. It's contraindicated in allergies. You want to be cautious with hepatic or renal dysfunction. Excuse me. Adrenergic blockers, you want to be cautious with patients that have known heart failure or coronary artery disease. Drug-to-drug interactions, alpha adrenergic blockers can have interactions with antihypertensive, nitrates, and erectile dysfunction drugs. So Viagra, what is the one that starts with a C? Cialis, I think. I have a star on page 942. So under contraindications and cautions, adrenergic blockers should be used with caution in patients with heart failure or known coronary disease, which could be aggravated by the drop in blood pressure or tachycardia. This is important. Finasteride and dutasteride have no indications for female patients and are contraindicated because of the androgen effects. They affect your testosterone. Okay. Family members or caregivers must be cautioned not to touch finasteride or dutasteride tablets because of the risk of absorption through the skin. These drugs will harm your fetus if you have one. If you are a woman, a biological female in childbearing years, you should never touch this drug with your fingers. If we were at clinical or in a hospital and I was working and I said, hey, I'm pregnant, can you pass this med for me? Or, hey, Jess, I just found out I'm pregnant. Can you please pass these meds for this patient? You do that for your friends, okay? Because pregnant people specifically should never touch this drug, and women of childbearing years should never touch this drug. I hope I have made myself very clear.
I have a question.
Okay? Go ahead.
Is that because women in their childbearing years, there could always be a risk of becoming pregnant, or would that stay in you, and then should you get pregnant, let's say a week or so later, it could have effects? Does that make sense?
It is the first option. Yes, very much makes sense. It's the first
Okay.
one. So
Okay.
because it really can just go straight into your skin, like transdermal, and it affects your testosterone levels so significantly, and you want to be very, very careful with it. But it's in that moment. It's not going to be something that's lasting forever. When you take this drug out of the Pyxis or the Omnicell, it literally pops up with a warning that says chemo precautions, PPE, because chemo precautions, not that it's a chemotherapeutic agent, chemo precautions are you have to wear gloves, you have to dispose of this in a proper way, and you have to wear the proper PPE. Are you okay? Why is everybody's looking at you. She's looking at you. She's looking at you. I'm like, are you okay? What's happening? Look at the two.
I have no idea.
Patients using either finasteride or dutasteride cannot donate blood for 6 months after the last dose to protect potential blood recipients from exposure to the testosterone blocking effects. Patients, should use contraceptives during and for 6 months following treatment and will not be able to donate blood during that time period because of the risk of exposing the fetus or blood recipients to the drug. That's if you take it, Amanda. So if you're actually orally taking these drugs, then you have to actively be on contraceptives and not get pregnant for 6 months. If you were to, by accident, it fell into your hand while you were giving it to a patient, is it going to affect your fetus? Probably not. Okay. So please make sure you know the contraindications and cautions and adverse effects of these drugs on page 242. Oh, drug-to-drug interactions with saw palmetto. Anybody know what that is? It is an over-the-counter herbal remedy. That's why it's always important to ask your patients what they take. Even if it's over the counter and it's an herb, those things mess with other drugs. Okay. And a lot of people don't realize that. This is looking at the drug called doxazosin, which always makes me think of an antibiotic, but it's not. It is indicated for the treatment of BPH. And there are adverse effects of headache, fatigue, dizziness, lethargy, vertigo, tachycardia, palpitations, sexual dysfunction is a big one. If your male patients are experiencing sexual dysfunction, what do you think they're going to do? They're not going to take it. It's a risk for non-compliance. Okay. Finasteride, adverse effects, impotence. What is impotence? We cannot.
Erectile dysfunction.
They cannot keep an erection. Yes. Decreased libido, breast enlargement and tenderness and gynecomastia. Yesterday, we talked about gynecomastia. This is the breast tissue growth in men. So all of these side effects, you really think your male patients want to take these drugs? No. An adverse effect of a bladder protectant is alopecia. True or false? It's true. It's associated with Pentosan. Used. Oh my goodness. Adverse effects associated with Pentosan include bleeding that may progress to hemorrhage relating to the drug's heparin effects, which I told you was important. Headache, alopecia, GI disturbances related to local irritation. All right. What time is class over today? 2. I need a break. Let's take 15 minutes. And then we need to get started on chapter 34.
Yes. Oh no, I've never known. I use my rice. Your bowl. Hello, orders of a sauce to take. There's only lots of chicken rice, chicken rice. I use in the pantry. Oh well.
forget what time they said. I know I said 15 minutes. I think they might have more.
Miss Simmons, can you let Octavia back in?
I don't have anybody in my waiting room. Yeah, I don't see anybody waiting. I don't know. I feel like sitting. Okay. Oh, there she is. Okay. All right, so this is going to be the introduction to the endocrine system. The endocrine system is large. It is very in-depth. So it works in conjunction with the nervous system to maintain internal homeostasis and integrate the body's response to external environment. Together, this is referred to as the neuroendocrine system. Chapter 34 starts on page 581. So the endocrine system includes glands and hormones that are secreted from said glands. So organized groups of special cells that produce hormones, we have the adrenal cortex, which is where? The kidneys. We have the intestines, kidneys, ovaries, which a lot of people don't realize that the ovaries actually do have their own hormone production. Your ovaries are responsible for secreting progesterone. When you first get pregnant, the corpus, I forget what it's called, but where the egg comes from the ovary, when it becomes fertilized and implanted into the uterus where you have a viable pregnancy, the progesterone production actually comes from that space within the ovary until about 10 weeks of pregnancy, where your brain and your pituitary take over. I specifically went through IVF, and because of that reason, because I didn't get pregnant naturally, I had to have progesterone injections in my butt for 10 weeks. It was terrible, but it was worth it. It was worth it for that little stinker. You also have the pancreas that secretes insulin, the parathyroid, the pineal gland, the placenta, stomach, testes, and thyroid. So this just shows you a nice little picture of all of the Ah, that's what it's called. I was right. The corpus luteum. See, I can't sit. Even if I want to sit, I just can't do it. I just can't do it. So you have all of these places in the body that produce hormones. So your ADH, diuretic hormone, oxytocin, which goes to the, what is that? Why it's called the luteal phase? Probably, actually. Also, I want to make sure I didn't get disconnected from my thingy. Yep, sure did. Check. Okay. Can everybody hear me?
Yes.
Somebody. Perfect. Thank you. I really was just going to sit down because that's my favorite today. Okay. So you have two parts, two like really big main parts of the endocrine system, which is the anterior pituitary and the posterior pituitary. Okay, so you have hormones that come from the posterior, you have hormones that come from the anterior. The hormones that come from the posterior are your ADH, which is the antidiuretic hormone, and then you also have the oxytocin. Oxytocin is our love hormone, makes us feel warm and tingly inside. And then the anterior pituitary releases melanocyte stimulating hormone, FSH and LH. FSH and LH are both important for men and women because for women, it goes to the ovary where your corpus luteum produces progesterone to make sure that your fetus is liable. What a day. Your fetus is not liable. Your fetus is viable. It helps produce testosterone in the testes. Then you have ACTH from the adrenal glands. You have your TSH from your thyroid gland, prolactin to produce breast milk, and the growth hormone for your bone health and growth. So hormones are chemicals that are transported in bodily fluids and act on specific target cells. Most of them are produced in small amounts and they're secreted directly into the bloodstream. They travel through the blood to those specific receptor sites. So remember, everything that happens in your body, not everything, most things that happen within your body is a lock and key mechanism, right? Something needs to fit in just like a lock and key or puzzle piece to make something else happen, okay? So with our negative feedback system, our body releases these hormones into the bloodstream because there's something lacking somewhere. And it's saying, hey, I need more of this. So then that gland releases that hormone, okay? So they act to increase or decrease the normal metabolic cellular processes when they react with their specific receptor sites. So they don't work unless they fit with their specific puzzle piece. They are present in the body at all times, but their amounts are going to fluctuate. So they are classified by chemical structure. You have proteins and polypeptides, which are the most prominent. So that means that the hormones are protein based. Remember I talked about essential proteins, how we need them. They are essential for human growth and development. They're also essential for our hormone regulation because we need them if they're the most prominent type of hormone. Okay. Some of them are steroids and some of them are amines. They act by linking to receptors on the cell surface. They cause effects via the G proteins or enzyme systems. Inside the cell, there are hormone receptor complex that can bind to the sequence of DNA. So it's just a really fancy way of saying that on the cell wall, there's something called a G protein. The G protein is the door, okay? The door with the lock. The hormone has the key to open that G protein lock to get inside the cell. Once it gets inside the cell, it then regulates the sequence of the DNA, okay? So it's very sciencey, but hopefully you understood what I did there. So the hypothalamus, it is the coordinating center for nervous and endocrine responses to internal and external stimuli. The hypothalamus, it's important to know, is the master gland of the neuroendocrine system. It used to be the pituitary, and then scientists changed their mind where it's not the pituitary anymore and is now the hypothalamus. So the hypothalamus is constantly monitoring the body's hemostasis by negative feedback systems, okay? So it does this by analyzing input from the periphery and the central nervous system, coordinating responses through the autonomic, endocrine, and nervous systems. So all of these symptoms are initiating your negative feedback loop and saying, hey, I need more of this. Or, hey, I have enough. Stop giving me this. Don't give me anymore. Okay? The hypothalamus is responsible for regulating a number of body functions. These are the hormones that are produced and secreted by the hypothalamus. So you have growth hormone, which is GH. You have thyrotropin, which is TRH. That is what tells the thyroid to make TSH. So the negative feedback loop starts when we're talking about thyroid. It starts in the hypothalamus by releasing TRH, okay? Gonadotropin, releasing hormone. Whenever you think of gonadotropin, think of gonads. Gonads is another term for sex organs like testicles or ovaries, okay? Corticotropin releasing hormone. Cortico, what does that make you think of? Steroids, corticosteroids, right? We already said that some hormones are steroid based. So corticotropin releasing hormone is going to be steroid based. And then prolactin releasing hormone, this has to do with our milk production. Prolactin does more than that, but it's mostly known for breast milk production. Inhibiting factors produced by the hypothalamus. GH release inhibiting factor is somatostatin. Okay, we'll get into what all of that means too. And the prolactin inhibiting, Jesus, I can't talk, factor. So when something is inhibiting it, then that means it's going to stop it. So if GH is the growth hormone that makes you grow, then the somatostatin is what stops it. Okay? If prolactin causes breast milk production, then prolactin inhibiting factor is going to stop breast milk production. Okay? There's two other hypothalamic hormones, which is the antidiuretic hormone, ADH, and oxytocin. I have a highlight on antidiuretic hormone. I'll get to it. Okay. Hormones function within the body in two ways. One way is for it to enter the cell and react with what?
D. K.
So we talked about it entering the cell wall. And then what did it do after that? So other hormones that are lipid soluble and non-polar actually enter the cell and react with receptor sites inside the cytoplasm or cell nucleus. When the appropriate gene regulatory proteins are present, the hormone receptor complex can bind the sequence of DNA. This will either activate or suppress transcriptions of genes. It's very sciencey. That's why endocrine is such a very specific part of healthcare, and it's so very specialized because it truly is so complicated. So, connection of hypothalamus to the pituitary gland. There is a vascular capillary network that carries the hypothalamic releasing factors directly into the anterior pituitary. So they are connected. There is a neurological network that delivers ADH and oxytocin to the posterior pituitary to be stored. Hormones are released as needed by the body when stimulated by the hypothalamus. So the hypothalamus makes the hormones. The anterior pituitary and the posterior pituitary store them. Okay, as little storage containers. There are three lobes to the pituitary gland. There's the anterior, posterior, and intermediate. The major anterior pituitary hormones are, again, the growth hormone, adrenocorticotropic hormone, which we shorten to ACTH, follicle stimulating hormone, FSH, luteinizing hormone, which is LH, prolactin, PRL, thyroid stimulating hormone, which is TSH, also called thyrotropin. These are essential for regulation of growth, reproduction, and some metabolic processes, and they're released in rhythmic manner into the bloodstream. We need every single one of these to be a normally growing human. The intermediate lobe produces endorphins and, I hate this word, enkephalins. They are released in response to severe pain or stress, also produced in peripheral tissues and other areas of the brain, and it secretes the melanocyte hormones. So, endocrine regulation. Hormones released in small amounts to accomplish what needs to be done to maintain homeostasis. These are really just like fine tuning everything through the series of negative feedback systems. So we have been talking about negative feedback systems since day one. Okay. Other hormones are released in response to direct stimuli. You have the hypothalamic pituitary axis. The hypothalamus and pituitary function closely using the negative feedback system to maintain endocrine activity and regular levels of certain endocrine hormones. So there is a constant check and balances going on. Constantly, constant. Homeostasis, what is the other word for homeostasis? What does it mean? Balance.
Balance.
It's our body's way of constantly finding balance. So, negative feedback system works like the law of supply and demand. So, the hypothalamus senses a need for a particular hormone. This is where it all begins. The hypothalamus secretes the releasing hormone or the factor directly into the anterior pituitary. In response, the anterior pituitary secretes the hormone and in turn stimulates the gland to produce more hormone. The hypothalamus will sense the rising level of hormones and stop secreting the releasing hormone. The feedback system is thought to be more complex than once believed. But really, it is truly quite simple. The body senses a lack of something, which triggers a domino effect. Okay? It triggers a hormone production. Something has to happen to increase what I'm lacking. Okay? So that is going to turn into a domino effect of I'm going to make the hormone, I'm going to secrete the hormone is going to go where it's supposed to go, and then I'm going to sense that there is enough going around, so I'm going to stop making it. Okay? If the demand isn't there, the supply is not going to be produced. So this is the negative feedback system of the thyroid gland. So it all starts in the hypothalamus. The levels of TSH influence anterior pituitary and the hypothalamus activity. So the hypothalamus says, hey, there's not enough hormones around here. So it is going to produce and secrete TSH or TRH to the anterior pituitary. The anterior pituitary is then going to release TSH, which goes to the thyroid gland. The thyroid gland is then going to say, oh, I need to release T3 and T4, which are then your thyroid hormones. Okay? So when the hypothalamus says, oh, okay, there's enough, it's going to stop the entire situation. Okay? The release of which hormone prepares the body for fight or flight. So we all know fight or flight is when your body senses danger. Okay? So in that in that danger, are we fighting the bear or are we running from the bear? Okay? So the adrenocorticoid hormones for ACTH activates the sympathetic nervous system, which causes the release of more ACTH, and this prepares the body for the acute stress response. Aldosterone, an adrenocorticoid hormone, is released in response to ACTH, but also is released directly in response to high potassium levels, which we know aldosterone is linked to potassium secretion, right? So we're going to cover fight or flight and the symptoms of fight or flight versus rest and digest in Complex Care 1. We're going to get into it really good. But it's important to know that there is hormone regulation in a stress response when fight or flight occurs. Okay? It's not just adrenaline making your heart race and making you run really fast, right? It's all about that hormone regulation. Okay, so chapter 35. This chapter focuses on hypothalamic and pituitary agents. So the main function of the endocrine system is to maintain homeostasis. We already discussed that. Too much or too little glandular activity disrupts homeostasis, leads to various disorders, or interferes with the normal functioning of the endocrine glands. So if there's something wrong with the way that your body is reacting to its negative feedback system, then that's when we get diagnosed with things like hyperthyroidism, hypothyroidism. What is the acromegaly? We're going to learn about that, where it's this just giant people that are 8 feet tall because they can't stop growing. Okay. So we already looked at that. All right. Factors that stimulate the release of hormones. Doesn't really say anything, does it? Chapter 35. Okay, so on page 590, the hypothalamus sees a number of hormones or factors to either stimulate or inhibit the release of hormones from the anterior pituitary. Factors that stimulate the release of hormones are, we already touched on a couple of these, but we're going to go into what they mean. So the growth hormone, thyrotropin, gonadotropin, corticotropin, prolactin, and then there's the factors that inhibit that growth. So somatostatin is going to inhibit the growth hormone. Prolactin inhibiting factor is going to inhibit the PRH. Okay. So there are hypothalamic releasing hormones and drugs that help our body make or release more of these hormones. So agonists are going to help create and release more. Antagonists are going to do the opposite. Okay. So Zoladex is synthetic gonadotropin. Since it doesn't want to tell us on the slide, I'm going to have you write it down. Hystrulin Leupride and nafarlin will block gonadotropin secretion. And then the available antagonists that block these effects are the antagonists down here. It's funny, I recognize some of these drugs from IVF. So the hypothalamic hormones found, they are in such minuscule quantities that chemical structures have not been identified. So not all hypothalamic hormones are used as pharmacological agents, but the indications are based on specific hormones. So it's like, hey, we know a little bit of that about this, but not a whole lot. So we're just going to give it to you anyways. The pharmacokinetics are based on each individual medication. Metabolism has not been studied for all of them. Most are excreted in the urine. So it's hard because if you're mimicking something that your body is constantly creating or supposed to be constantly creating or mimicking, it's almost as if you have to monitor what happens in the body if your body just creates too much of it. Because when it comes to synthetic hormones, they want to make them as realistic as possible so that it is as similar as the actual hormone. Contraindications are for known allergy and pregnancy and lactation. You want to use caution in patients at risk for cardiovascular disorders, rhinitis, or sneezing immediately after administration of nasal spray. This is because it could alter the absorption of the nasal spray. So if they have a runny nose or they're immediately sneezing right after, because a lot of these drugs can be given intranasal, it's going to alter the way that they metabolize them. Are they even getting it? Are they getting all of it? Are they getting this much of it? How do you know how much they're getting if they're going to sneeze right immediately after? So if we look at the table 35.1 on page 592, it talks about these drugs. Some of them are subcutaneous. Some of them are implanted. Neferilin is a 1 spray in the left nostril in the morning, 1 spray in the right nostril in the evening. And the rest of them are sub-Q. So it looks like the only intranasal spray is the Neferilin. This is for the treatment of endometriosis and precocious puberty, which is why it's given to children a lot. I think one of the most important things to know that I just said is the rhinitis and sneezing, because how do you know how much of the drug they're getting? So adverse effects are related to stimulation or blocking of the regular hormone control. The agonist can trigger the initial disease to flare up, because if your disease process is caused by this hormone production, and then you're giving them an agonist that's going to promote more of that hormone, then it could cause a flare in their symptoms. Injection site reactions, you're always going to be at risk for injection site reactions when you have sub-Q or IM injections. These drugs are sub-Q. So this is looking closer at leuprolide. This is for the treatment of advanced prostate cancer, endometriosis, central precocious puberty, and uterine leiomyomata. So this drug is an agonist and causes an initial increase, which could cause an increase in their flare, but then profound decrease in LH and FSH levels. So it's working on the ovaries and the testes, because FSH and LH are gonadotropins, right? They're for the sex hormones. Drugs affecting the anterior pituitary hormones, these are used mainly to mimic or antagonize the effects of specific pituitary hormones. They're used to replace or for diagnostics. Growth hormone agonists. You have somatotropin, which is the most common of this group, the agonist, somatotropin. And then for growth hormone antagonist, your bromocriptine and octreotide are most common. Okay, so when we're talking about the agonist, like the somatotropin, the therapeutic actions is to stimulate the overall growth and production of protein. It binds to the growth hormone receptors, and it's for treatment of growth hormone deficiencies. So if your kid is not growing correctly, you have a child that is 3'2" when they're supposed to be 4'2", and the doctor is like, hey, something's going on. They're having a lack of growth hormone. We can use drugs that stimulate the growth. Okay. So somatotropin is injected. It reaches peak level in 7 hours. The second one is injected. It has a peak 4 to 24 hours to reach max concentration, 1 to 2 weeks for steady state. It's widely distributed in the body, excreted through the urine and feces. They're contraindicated in allergy. This is the most important part. The somatotropin, these drugs are contraindicated in the presence of a closed epiphysis. What is an epiphysis? Epiphyses. It's a funny word. Growth plate. Yes. So when your growth plates close, there is no more growth within that bone. Okay. Your bones end in epiphyses, open epiphyses. So when your child reaches a certain age, that epiphysis plate is going to close, which then they are no longer capable of growing that bone. Okay.
Miss Simmons,
Yeah.
my iPad won't stay charged. Can you let me in on my phone, please?
Oh, yeah.
Thank you.
Mm-hmm. So when you have a deficiency in growth hormone, you can have a deficiency with skeletal growth, growth of internal organs, protein synthesis, and the stimulation of many other processes that are required for normal growth. So this is all on page 595. GH deficiency in children results in short stature, which is known as dwarfism. Adults with somatotropin deficiency syndrome may have hypopituitarism as a result of pituitary tumors or trauma, or they may have been treated for deficiency as children. So adverse effects that occur most commonly with GH replacement include injection site reaction, always. If you're injecting anything, there's always going to be a risk for injection site reactions. Edema, myalgia, and arthralgia. This is very important. Do you guys remember growing pains? Do you know at some point, like, people or doctors did not think that they were actually real? I remember waking up, I have no idea how old I was, but like screaming for my mom because my legs hurt so bad. And she would put like icy hot on my legs and then my legs would get really, really cold. So I'd wrap them in blankets. But it really was the bone growth, not muscle pain. I mean, yeah, the muscle was stretching with the bone, but it was the bone growth that is so painful. So if you're stimulating bone growth in children with epiphyses that are not closed, so they're capable of massive growth, they are going to have muscle, joint, and bone pain. So it's important that we educate our patients, the children and their parents, that this is going to be something that could happen. Insulin resistance and hyperglycemia should be monitored. And they may need to be, the anti-hyperglycemic agent may need to be increased. So that would also be a very important thing to teach your patients. Drug-to-drug interactions include glucocorticoids. And this is just looking closer at somatotropin. So somatotropin is used for the treatment of children with growth failure due to the lack of growth hormone or to chronic renal failure. Replacement of the growth hormone in patients with GH deficiency, long-term treatment of growth failure in children born small for gestational age who do not achieve catch-up growth by 2 years of age. Treatment of short stature associated with Turner syndrome or Prader-Willi syndrome. Also approved to increase protein production and growth in various AIDS-related states. Replacement of endogenous GH in adults with GH deficiency. Treatment of adults with short bowel syndrome. So it stimulates skeletal growth, growth of internal organs, and protein synthesis. So these patients do not have enough growth hormone. Okay. Adverse effects are development of antibodies to the growth hormone, which could then trigger kind of an autoimmune response where your body starts attacking that hormone production. Insulin resistance, swelling, joint muscle pain, headache, injection site pain. So when we look at these things, I want you guys to remember and think about, what does my patient need to know? What do I need to teach them? If you are putting my child on somatotropin for a growth hormone deficiency, you better tell me that my kid's probably going to wake up in the middle of the night screaming in pain, or I'm going to need to treat them with some type of pain medication. I need supportive care for me to provide to my child. Okay. True or false, somatotropin is a hormone of recombinant DNA origin that is equivalent to human growth hormone. So it's derived from DNA.
True.
So synthetic human growth hormone is now available from recombinant DNA sources using genetic engineering. So that means it is extremely close to the real thing. Extremely close. All right, so we are going to stop there because the next thing we're going to talk about is caused by excessive growth hormone. So we just finished deficiency with growth hormone, and then we're going to go into too much. So what I'm probably going to do is send you a list of key points that I want you to look at before Monday so that you can study these things before I talk about them, so that when I'm talking about them, it's not the first time you're hearing it. Okay, I think that would be really helpful, especially because it is the day before your exam. Any questions about anything?
More of a statement, but I'm pretty sure that none of this was taught to us the first time around. So much of this is
absolutely
like
was
new
not.
information to me.
It
Yep.
was
For real?
We learned about the thyroids, yeah.
Everything is brand new.
And also,
Wow.
while we were in one of our foundation classes, our teacher didn't like the endocrine system, so she did a lot of blah 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 blah. I don't really care about that, and we didn't learn much of it. So,
Who was that?
Stephanie Baden.
Of course it was. Of course. Of course it was.
So you thought our nerves were bad for today's exam? Now just imagine next week's.
Oh, goodness gracious.
I'll read it. I'll do.
So this isn't the first time you're hearing it?
That necessarily, but de-stress that.
Good.
Oh, yeah. That was like, I think the hardest part of that search too.
Endocrine is notoriously one of the most difficult systems to understand because it's very complex. Very
it's
complex
the most
system.
complex one.
Yeah.
They have a lot of hormones, a lot of really big hormones.
Yeah.
Like diabetes.
Because unless you work in endocrine, it's really hard to like make this stuff stick and think about, you're not thinking about this stuff every day. You're not doing it every day. That's why endocrinologists are so hard to find and so specialized because it's very niche.
That makes sense.
I bet you have to wait forever to get into an appointment too. Or if he's established, maybe you don't.
I did not have to wait forever to get him established because he is oncologist to him.
Mm-hmm.
So they're very pushy and get things done in a very timely manner.
Yeah.
But when he started losing weight, they had him in within 2 months.
Wow.
Yeah, though.
Well, I have questions about that, so I'm going to be asking you about that later.
About the oncologist. Yeah, that's fine.
Yeah.
That's why I want to specialize in his pediatric oncology.
I love that. Will you close the door? Thank you. Oh boy, guys. What am I going to do about you?
You know, and it also sucks because a lot, not you, I think you're absolutely amazing. I mean, I do. So it's not you. So please don't. But a lot of these instructors also don't take into consideration that a lot of us don't work in the medical field or haven't had that experience and we're just getting into it. Like I'm an extern at a hospital. I have been for a few months. And even when I'm like working, the nurses are like, oh, you'll learn it once you pass your NCLEX and get on the floor. Like, you're okay. Just go past these meds. You know what I mean? And it's just so
No
hard
way.
to like get that
No way.
experience. And
That
then
is
I
so
also get told, I'm sorry.
That is so inappropriate.
It is, and it sucks.
To say that to you.
Yeah. Or like, you know, there's a few instructors at the Niles campus who says, you know, what you're learning in school is totally different than what you're doing outside in the real world. So whatever you learn in the real world won't be the same as an ATI exam or the same as an NCLEX. So I'm getting a little confused and it's disheartening all around.
Can I address that? Let me just address that. So I hate when nurses and nursing instructors say things like that. And it's because when I'm echoing, oh, thank you. So it's because when you are in nursing school, you are held to the highest standards. You are held to the standard of making morally correct, ethically correct, and safe options. safe choices. The people that are telling you that are the people that don't want to follow the textbook rules. They want to do shortcuts, and don't get me wrong, have I done shortcuts as a nurse? Absolutely. I've been a nurse for 8 years. I mean, you really think that that I didn't get sick of wearing an entire full PPE during COVID in the ICU, and that when I had to go into my patient's room that was ventilated, after I had been working in the ICU with COVID for 6 months, that I put my mask on, walked in really quickly to restart the IV, and then walked back out without all of my proper PPE? Yeah, absolutely. Because first of all, I don't want to waste resources, and I don't want to put on all of that stuff just to hit one button when I'm not even providing patient care. Was it dangerous? Yes. Was it stupid? Yes. Did I do it? Absolutely. So there are always going to be moments in your nursing career that you're going to take a shortcut, that you're going to do something that isn't the textbook NCLEX nursing school clinical way. Absolutely. But the point of all of this is what you're learning is to provide safe, the key word is safe, and effective care. And those standards are standards that you should take with you for your entire career. Whether you are a nursing student, you are an RN with an ADN, you are an RN with a BSN, you are an RN with a master's degree, you're a nurse practitioner. Your responsibility only grows from here. Right? So as soon as you pass your NCLEX and you have your license, you now have an entire responsibility for a human life that you've never had before. And the farther you go up, the more responsible or the more acute care that you provide, the more responsible you are for a patient's life. So really, at the end of the day, it's your choice as a nurse whether you're going to provide safe, effective care or you're going to do shortcuts every day, every moment that you can in your career. You see what I'm saying? So what I believe that saying that to you is unacceptable. Because just because they are following footsteps that are different and shortcuts doesn't mean that they should be teaching you how to do such things. Because there are things in nursing that should never be shortcutted, ever. Because that becomes extremely unsafe. You know, when you guys remember Ebola? Okay, the nurse from Texas, she contracted Ebola because a piece of her hair was outside of her PPE. One piece of her hair. And that is how she contracted Ebola and almost died. So when you as a nurse are weighing your risk versus reward of the shortcuts that you're going to take in your career, that falls on you, and that falls on your license, and that falls on your heart and your head. When you go to sleep at night, you have to be okay with what you did that day. And believe me, that first year of nursing is the hardest when you lay down after a 12-hour shift and then you think about all of the crazy things that you did that day and running around like a chicken with your head cut off. And you just think, oh my God, I should have done this, or I should have done that, or oh my God, I forgot to do this. Or your first patient that codes, your first RRT. You are going to lay in bed that night and you're just going to play it in your head over and over and over and over again. And you have to decide what you can live with at the end of the day. Is it always going to be that serious? No, it's not. Was it really that serious that I walked into that patient's room without a gown on? I was fine. I took a risk. The nurse with Ebola took a risk because she didn't put her stuff on correctly, and then she contracted a horrible, deadly disease, and thankfully she did not die. So I don't think it's very kind or acceptable for your instructors to say those things to you, or your preceptors to say those things to you. Because yeah, someday are you going to have a order for Protonix, give an IV push? Are you going to sit there for 5 minutes like it says to push over 5 minutes? Probably not. Probably not. But guess what? If you rapidly push Lasix, you could cause your patient to go deaf. So you're going to follow the 2 minutes on Lasix? Probably. So you have to make the choice. I'm going to finish my rant because I could get really animated about this subject, which I feel like I already have. So it's pretty crazy that you guys didn't talk about these chapters, because these chapters are literally on your syllabus. And I mean, you can ask my previous students, they absolutely were tested on these chapters. We went in depth on the endocrine system. And it was a very difficult exam for a lot of my students because of how important it is. So I have no idea how they got away with not teaching this material.
We were told to go on into the textbook and study the chapters.
I'm going to stop recording.